Today we're going to talk about a very, very interesting and an important discussion topic of hyponatremia. Now, hyponatremia is one group of disorder which has got a lot of endocrine issues. So what we'll be focusing today is largely in terms of the endocrine issues. And hyponatremia is one condition which, if it is diagnosed at the right time, we can manage it appropriately, we'll have a good outcome. But if we delay the diagnosis, there could be a problem. With this first case, a 14-year-old boy with drowsiness who was found to be hyponatremic, and on evaluation, the child was clinically euvolemic. The urinary sodium was done, which was found to be high. So we have hyponatremia, which is a dilute blood with a concentrated urine. So urinary sodium of 100 would mean that the osmolality would be around 400. So roughly you make it 4 times, it give you the osmolality from that regards. It was around 300 and was diagnosed as SIADH. So this is a euvolemic hyponatremia with a concentrated urine. SIADH is a reasonable diagnosis. But what happened with this child was that had a severe worsening here. And when the endocrine team was evaluated and asked for, it was found that this was actually not a case of SIADH. It was actually a case of multiple pituitary hormone deficiency. So again, before we start considering different diagnoses, so a lot of these hyponatremia will not be endocrine. But if you identify an endocrine cause, unless you treat it, there would be a problem. And this is a common situation wherein SIADH is often misdiagnosed in somebody who has a multiple pituitary hormone deficiency. And we always say that SIADH is a diagnosis of exclusion. You have to exclude cortisol deficiency, renal insufficiency, hypothyroidism, diuretic use before you make a diagnosis of that. And that was the error which happened in that situation. The other situation, again, a 16-year-old girl with abdominal pain, recurrent abdominal pain was there and now presented with seizures. So she was basically called, we were called when the sodium was found to be low. So this was a child who had euvolemic situation with hyponatremic seizures. And when we did evaluation, it found out that she was euvolemic, every other workup was normal. So this was SIADH. Now, the message again is that don't end your story with SIADH diagnosis, because SIADH is just a syndrome. You need to go at an underlying cause. Now, in this setting, we had a girl, a young girl with recurrent severe abdominal pain and seizures. So what was very important and what we got at that point of time was the urinary porphobilinogen, which was positive for porphyria. So what these two cases tell us is that don't be in a rush to diagnose SIADH, exclude the possibility of other endocrine causes which may mimic SIADH, or other causes, pathologies like porphyria becomes important. And that is why hyponatremia is a challenge. If you identify it at the right time, identify the diagnosis, the treatment will cause a very good outcome. But often there is a confusion which may happen in that regard. So all of you can go and have a look at our website, learning.growsociety.in, where there are a lot of information available about different aspects of pediatric endocrinology. We have got over a number of modules, around 100 modules, which are available along with assessment and validated tools. We got specific courses in the form of fellowship and diploma courses, along with courses for postgraduates and a specific electrolyte course as well. We run 3 grand rounds every month. So we have got this, which is a grand round, then there's a postgraduate grand round, and there's a postgraduate lecture series. And later today, we have got a postgraduate lecture series on growth hormone therapy. That's 9 p.m. later today, which you can join from that regards. There are publications, both basic and advanced, which you can access. And our mobile application, we'll also use that application to decide about how to treat hyponatremia, which will be identified in this perspective. Now, before we go into details with regards to the various causes, evaluation, and cases, we need to understand the basic homeostasis. Now, what we need to understand is that when we talk about the sodium level, the sodium concentration in the body largely depends not on your sodium, but on the free water. So sodium is a major determinant of volume, and free water is the major determinant of tonicity, that is sodium levels. So if you now think about conditions which are more common causes of hyponatremia, be it fluid overload like cardiac failure, liver disease, nephrotic syndrome, all those situations, conditions in which you have got inappropriate ADH excess or appropriate AVP excess, fluid overload is a major cause of hyponatremia. What are the conditions which are associated with sodium loss as a cause of hyponatremia? So any cause of renal or extra-renal sodium loss. So we are saying that fluid excess is a major cause, but if you're losing a lot of sodium from your gut, like diarrhea, a lot of sodium through your urine because of diuretics, tubulopathy, RTA, or RAS defect, you will have hyponatremia. But do you think there also is an issue of free water there?
Yes.
Why?
Because that water is also lost.
So, because you lose water, you will have a situation in which you will have excess production of AVP. And whenever you have excess production of AVP, your free water level will go up and you will have hyponatremia. So anybody who has got chronic hyponatremia will have an excess of vasopressin, whether it is appropriate or inappropriate. And ultimately, it is the free water excess which is the major cause of hyponatremia. Salt loss can cause that, but then body will adjust. As soon as you lose salt, body will try to develop mechanisms to do that. But if you've got too much free water, it will be very difficult from that perspective to identify and evaluate in that regards. Now, there are two ways your fluid status is assessed. One is via thirst, so how much water you are taking. And the second, of course, is how much urine you are passing. So the thirst is the main defense against hypernatremia. If your sodium goes up, you will stop your urine output, but you have to drink water to ensure that the sodium levels come down. On the other hand, if you have hyponatremia, just by stopping to drink, your hyponatremia will not be corrected. You will have to shut down with regards to the urinary concentration which is happening. You have to allow the urine to be lost, and that will be helpful. So if you talk about hyponatremia, the major defense against hyponatremia is the body's capacity to lose free water. Now, if you go other way around, the most common cause of hyponatremia would be the situations where the body cannot lose free water. And if you cannot lose free water, your free water will be more and sodium will be going down. So in a nutshell, every child who has got hyponatremia has got high AVP, has got a low level as far as the urinary loss is concerned, and the urinary concentration happens. So most cases, your urinary sodium levels would be in that setting on the higher side. While the normal response should be that the urinary sodium concentration should be low in that setting. And this is an important thing to remember from that regards. Now, in situations wherein your tone increases, now this is the other way around. If your tone increases, the hypothalamus, the circumventricular organs which are located in the organum vasculosum of lamina terminalis and subfornical organ will say, okay, now we need to get more free water in the system. What they will do in that perspective is that they will then secrete AVP, which will decrease urinary water excretion, causing increased free water. This is a normal response in the setting of somebody who is developing increased osmolality, increased tonicity, or hypernatremia. Let's put it in that perspective. Now, in a situation where volume goes down, and whenever your volume goes down, the major response comes from the renin, angiotensin, aldosterone system. And this RAS system will then do a very important thing. It will allow sodium to be resorbed along with loss of cyan. If you absorb sodium, what are going to you lose?
The potassium.
And?
The potassium and all the other positive ions.
Potassium and proton. So these two things will definitely be lost. So anybody who is having hypovolemia, so let's talk about diarrhea, let's talk about diuretic loss, let's talk about tubulopathy, let's talk about RAS defect, you will have RAS excess. Unless, of course, there is RAS defect, you can't have RAS excess, everybody else will have RAS excess. When you have RAS excess, your potassium will come down and you will have alkalosis. So hypokalemic alkalosis is a normal response to somebody who has got a low level of sodium if the RAS axis is intact. If the RAS axis is not intact, of course, you will not lose potassium and you will not lose proton in that perspective, and that could be a problem in that regards, and you will develop a hyperkalemia and acidosis. So anybody who has hyponatremia with hyperkalemia with metabolic acidosis, you're talking about a defect right at the renin, aldosterone production, aldosterone action, and all those situations will have a problem which will happen, and that's what the RAS defect will present with. Hyponatremia, hyperkalemia, and metabolic acidosis would be the usual response in that setting. Now, as discussed, normally we say when your sodium goes down, your potassium goes up. When your sodium goes up, so in pathological causes, if your sodium goes up, your potassium goes down. So typically I said if you have hyponatremia with hyperkalemia, you're talking about largely a renin, angiotensin, aldosterone defect. What other condition will cause hyponatremia with hyperkalemia? Vibha. Hyperkalemia. So hyponatremia, hyperkalemia, renin, angiotensin, aldosterone, pseudohypoaldosteronism, CAH, all those things are there. What other condition causes hyponatremia with hyperkalemia? This is a very common condition. So we talked about adrenal problem causing hyponatremia, hyperkalemia. What else will cause hyponatremia and hyperkalemia? Diarrhea, no? Potassium sparing diuretic is the RAS axis only, na? So kidney disease, any cause of acute or chronic, not even acute also causes hyponatremia, hyperkalemia. Now, what is the difference between hyponatremia seen in a renal problem versus hyponatremia in the adrenal problem? Renal problem is because of? Fluid overload. That's a dilutional hyponatremia. While in the setting of adrenal problem, you will have hemo concentration, that is dehydration. So again, if you have hyponatremia with hyperkalemia, the first question you will ask is whether this is renal or adrenal. And this will become relevant because once we discuss this in that regards, the answer to that question is to look at hydration status. If the patient is dehydrated, this is mostly a salt wasting crisis because of an adrenal problem. If the patient is actually fluid overloaded, there is edema, it is more of a renal problem. Which biochemical parameter will tell you that the patient is having hemo concentration or hemodilution, because often volume status in young children may be difficult to assess.
And uric acid.
Yes, so uric acid and hematocrit. Why uric acid?
When the volume is more, uric acid is excreted more.
The excretion of uric acid is directly proportional to the blood volume. More the volume, more loss of uric acid, low uric acid. So if you have renal problem, unless of course the uric acid excretion is defective and that you may have hyperuricemia, or let's say if you have SIADH, in that setting your uric acid will be low because your volume is more. While if you have an adrenal pause, your uric acid will be high. So looking at hematocrit and uric acid, you will know which way to go forward. So I said hyponatremia with hyperkalemia, renal versus adrenal. What about hyponatremia and hypokalemia?
This is mainly due to tubulopathy or sir, diabetes.
So any tubular dysfunction and diarrhea. So you are losing both sodium and potassium, either through your gut or you are losing through the kidney. So you will have either diarrhea or you will have a tubulopathy, Bartter syndrome, Gentleman syndrome. You can have cystic fibrosis also. You will be losing to the sweat. So you're losing it from somewhere and that will cause a problem. So again, understanding the pathophysiology will help in that perspective. Now, if you give too much volume or your volume becomes more, the body will say, okay, I have to shed this volume. And how do it detect? It will then have a signal in the heart, because heart is where all the volume is coming. So atria, once they feel, okay, a lot of fluid is coming, we have to get rid of it. There's a specific system there, which is the atrial natriuretic peptide, which then goes on and does two major things. One is it will cause loss of sodium directly. And secondly, it will inhibit aldosterone. So any condition where the volume increases, ANP will be more. Now, what role does ANP have? Do you know of any condition which is causing hyponatremia where ANP is causing a problem? Vibha. So any condition with high volume? let's put it this way, you have cardiac failure, you have liver disease, you have renal failure, you have got SIADH. SIADH is actually a hypervolemic state. As soon as the volume goes up, ANP goes up. So ANP is the second perpetuating mechanism which is going to cause your loss of sodium. So now let's go this way. We said that you have too much free water or you have loss of sodium. That is why your sodium becomes less in that perspective. If you have got too much volume, ANP comes into the picture, that will cause more loss of sodium in that perspective. The other thing would be that if you have got less volume, then which thing will come into picture? RAS axis and AVP will come in. If you have less volume, AVP will come in, and AVP will also cause more free water. So in a way, there are two mechanisms which increase this vicious cycle of hyponatremia. One is that if you have too much volume like SIADH, your atrial natriuretic peptide will come into the picture. It will cause sodium loss. While if your volume is less and you are severely hypovolemic, I'm not talking about 2%, 5%, I'm talking about 10 to 20% dehydration, then atrial, then AVP, the vasopressin will come up, and that was going to cause you further hyponatremia. Now, the main problem with high ANP in SIADH is that if you give them sodium, what is going to happen? You say, okay, they are hyponatremic, I'll give them normal saline. What will happen then?
You can give normal saline because of the ANP action, sodium loss will be there.
So body is ready to lose sodium. So as soon as you give sodium chloride, it will lose all the sodium. It will, because the ANP is high and aldosterone is low. So that's a tricky situation. So if you understand this slide, you will basically understand the entire pathophysiology from that perspective, and that becomes important from that regards. Now, if we know now this much, we'll now move forward to the what could be the causes of hyponatremia. So as I said, hyponatremia is largely a free water issue. So most cases of hyponatremia are because of having too much of free water. Like hypernatremia is because of too little free water. It's just the opposite thing. So you may have more free water because of a cardiac failure, nephrotic syndrome, chronic liver disease. Those situations you will have more volume. Now here you have effective hypovolemia. There is a third space collection. Because of effective hypovolemia, your RAS axis will go up. So your potassium, you will have hypokalemia, alkalosis may happen. Your AVP will also go up. And that's why also you will have further worsening of hyponatremia, which will happen. Then, of course, if you have any reason for body to produce AVP, which is inappropriate, that is SIADH, and there are so many causes. What are the major causes of SIADH in children?
SIADH will be secondary to any infective cause.
Like
or pulmonary infection, or
largely in the setting of bronchiolitis, pneumonia, meningitis, tubercular meningitis, these will be the features. But don't forget about drugs. A number of chemotherapeutic agents, vincristine, vinblastine, cyclophosphamide, ifosfamide, they will also cause a similar picture. A lot of SSRIs and substance of abuse, ecstasy, these all drugs will also cause. So these drugs, infections, these are the largely two things. And I said porphyria also as one of the causes, and mechanical ventilation, Guillain-Barré syndrome. There's so many causes, but you have to consider SIADH importantly. Very important to remember that if you have a deficiency of thyroid or cortisol, you will also have increased volume and causing hyponatremia. Now, my question to you, Vibha, is that if you have somebody who has got an isolated cortisol deficiency, what will happen to potassium? So the message is that if you have hyponatremia, even if the potassium is normal, it does not mean that you have ruled out cortisol deficiency. When there is a combined adrenocortical deficiency, both cortisol and aldosterone defect, you will have hyperkalemia, which will happen in that setting. While here your potassium levels may actually be normal or low. So look at sodium, don't just look at potassium in that perspective. The other big message is from the first case, as I said, that if you have got anybody with your diagnosing SIADH, always exclude thyroid and cortisol deficiency, because that's very, very important from that regards. Now, sodium loss can also happen, but this alone is not good enough. You will need to sustain it either via excess AVP, and that is going to cause it more worsening. This sodium loss could be a RAS defect or tubulopathy. What would be the difference in potassium levels in RAS defect versus tubulopathy?
potassium level in RAS defect will be high. It is hyperkalemia. In tubulopathy, sodium and potassium both will be low.
Okay, so very good thing to know is that if you just know potassium, you can classify that. So now how will you distinguish? Now, if we build up approach here only, it becomes very easy. If your volume is more, you are dealing, or your volume is more, you are dealing with these conditions. If your volume is normal, you're dealing with SIADH or hypothyroidism cortisol deficiency. If volume is less, you're dealing with either RAS defect or tubulopathy. There you do potassium. So all you need to know is the volume status, potassium. Maybe if you are in doubt about the volume status, look at hematocrit and uric acid and urinary sodium. These 4 or 5 tests will really tell you which is the diagnosis, how you should go ahead in terms of treatment from that regards. And of course, diuretics, cerebral salt wasting, these all factors are there, which you will know that there is a CNS insult and there is a salt wasting which is there. So hyponatremia can be because of excess free water, which is basically associated with U, or hypervolemic with a low uric acid because you have got more volume. The cause here, or sodium loss, in which you will have a hypovolemia with high uric acid in that perspective. Excess free water can be cardiac, liver, or renal in that perspective. And in this setting, your urinary sodium will be low. Why is the urinary sodium low in this setting?
Sir, again, volume deficiency.
So there is a intracellular. So it's the third space loss is there, but actual you have effective hypovolemia. So body is conserving. So you will have a urinary sodium which is low in that setting. While reduced loss is largely SIADH or cortisol deficiency, the urinary sodium here will be more than 25 in that perspective. Now, sodium loss can be extrarenal like diarrhea and cystic fibrosis, where body will then like to conserve the urinary sodium. It will be less than 25. And finally, renal loss, which can be either tubular or adrenal, where the urinary sodium will be more than 25. So if you look at 2 levels, I talked about volume, U versus hyper, and urinary sodium, you know which way you're going. If you want to distinguish tubular from RAS, look at potassium. So if you just remember this algorithm and look at volume, potassium, and urine sodium, your diagnosis is done. It's not very difficult to do in terms of hyponatremia evaluation. Now, one question which is easy to say but difficult to do in practice is it free water excess versus sodium loss? Because that's the fundamental thing. So of course, you want to look at volume, but often in small children, volume may not be very easy to say whether it is euvolemic or not. So fluid status will be one, of course, but as I said, you can use other surrogate parameters. If your uric acid is low, if hematocrit is also low, it means there is a hemodilution which is happening. While if you have got high uric acid and a high hematocrit, it goes more in favor of a concentration. So again, renal versus adrenal. This is the question which often happens. Your answer would be hematocrit. So if you have somebody who comes to you at 4 weeks of life with hyponatremia, hyperkalemia, and has a hematocrit of 68, it is unlikely to be adrenal because creatinine may be high even if it is a pre-renal failure. So that may cause a confusion. So there is hemoconcentration. It means there is a problem in the adrenals, not in the kidneys. In that reading. So main test to look at are potassium, uric acid, urinary sodium, and these ones will give you the diagnosis. So let's go one by one. Uric acid will be low if your fluid is more. So I find it very, very helpful in differentiating between SIADH and cerebral salt wasting. Now, this is a typical setting. Somebody is in the neurosurgical ICU, is developing hyponatremia. The question is it CSW versus SIADH? Now, to distinguish between the two, you can say, okay, look at the volume status. There is hypovolemia or not. You look at the level of urine output. It may be of help in that perspective or not. And the other situation would, of course, be to look at uric acid. So uric acid will be less than 4 in that setting. And I often find it less than 2, which becomes very, very easy to distinguish between these two conditions. Urinary sodium, I said, if the urinary sodium is high, it means you're losing through the urine. That is the basic cause. Potassium, if the potassium is hyponatremia with hyperkalemia, renal versus adrenal. Hyponatremia with hypokalemia, tubulopathy or GI loss. And normal may be all these SIADH, fluid overload. These conditions will give you a picture. And hemoglobin is again a marker of concentration. So hematocrit will be a good picture. So not many tests are required. Basic tests will give you the diagnosis. So look at fluid status. Of course, you have to exclude a possibility of hyperglycemia, which may cause pseudo-hyponatremia, but you will know that this patient has decay. There's no confusion. Ion selective electrodes that we are using now will not be affected by increased amount of lipid or protein. So that's not a big problem now. If fluid status is hypervolemic, you know these three conditions, cardiac, renal, and these patients you will know that there is a liver disease, and then they will have hyponatremia. They will not come the other way around. If they are euvolemic, do a thyroid and cortisol. If it's normal, it is SIADH. If it is low, it is MPHD. Work up accordingly. The issue is here, if you have hypovolemia, then urinary sodium, if it is low, it is extrarenal. If it is more, look at potassium. If there is hyponatremia with hypokalemia, think of tubulopathy and diuretic use. If there is hyponatremia and hyperkalemia, think of a RAS defect.
An old boy who is birth of non-consecutive marriage had admitted for the persistent vomiting, and patient having altered sensorium at time of the admission, and a patient having blood sugar, hypoglycemia, blood sugar of 40 milligram per deciliter.
Stop there. So if you have a child, 10-year-old child who was normal till now, complains to you with vomiting, altered sensorium, and hypoglycemia, what are the things you would think of?
Sir, I can.
Let's say even before hypoglycemia.
So it can be due to the acute illness because of like diarrhea, because of the decreased oral intake. It could be due to the vomiting also. So
10-year-old boy, you expect because of diarrhea will become altered sensorium?
Sir, with diarrhea, with some infections.
Very, very rare. It will be very rare for 10 years to become altered sensorium in the big issue. So what will you think of more?
Sir, might be associated with hyponatremia or other.
So why don't you think of a CNS problem? An important thing could be some CNS infection which is causing, because altered sensorium does not happen with simple diarrhea. That too in a 10-year-old child, it will be very, very unlikely. So you have to start thinking here that there are two things. There is vomiting and there is altered sensorium. So CNS, it means there is a raised IC. Let's put it this way.
Okay.
Now, one, of course, before you go ahead in terms of this particular case, you will think of other possibilities as well. So CNS pathology will become important in that regard. Now, when you say altered sensorium, what do you mean by that?
Means patient was not oriented to time, place, and person, and patient was unconscious.
So was in a comatose state?
No, it is like.
So it was more like a drowsiness than actually altered sensorium, because that will be a different perspective. Because if they are totally altered, then you will think of more of an acute neurological insult. But this looked more like a evolving thing in that regard. Now carrying forward.
So in this case, on examination, there was mild to moderate dehydration was there. Child having history of vomiting that started with since 2 days. That was not associated with headache or any fever. Patient having history of gradually weight loss since the 2 to 3 years, and history of recurrent vomiting and multiple admissions since 8 years of age.
So stop here. So again, this is an important phenomenon. You've got somebody who's got recurrent episodes of vomiting and admissions, which used to improve over time. So in between that illness, was he normal or not?
Sir, according to mother, child was not that active as before.
And he was losing weight during this period over 2 to 3
years. He has lost weight.
So this doesn't look like an acute
illness.
So now this becomes less likely to be an acute CNS infection, or a pathology becomes less likely. It looks more like to be something which is going on, and in between he becomes worse. One specific question in this setting which will help you out in that perspective would be whether he had admissions more in summer season. Because this is often we see that patients who have got Addison's disease or patients who have got Sheehan syndrome, let's put it the other way around, they often become sick much more when there is more heat. So during summer season, they will require much more hospitalization, which is there. So this is again, now this means there is a chronic recurrent vomiting and hospitalization. Maybe he's getting something in the hospital which is improving, and we know a lot of people will give steroids. A lot of the people who are not, they will routinely give steroids as part of it, and that may also cause improvement along with saline.
So there was a history of polyuria in this child, and there is a history of hyponatremia while past multiple admission in the documentation.
I think that is a big issue. If somebody has documented hyponatremia, and somebody who is requiring hospitalization, we have to read the diagnosis, we have to read the cause. It is not appropriate to just stop that hyponatremia was there. So that is a big thing which was done in this case, which was missing in that regard. So now, if you talk about the hyponatremia, so what are the features of hyponatremia?
Sir, in this patient,
clinical features.
Sir, in the hyponatremia, there should be the might be associated with the dehydration or the volume. According to volume status, we can decide the picture.
What are the presenting features of hyponatremia? I'm not talking about how do you diagnose cause of hyponatremia. What does hyponatremia cause? The other way around.
Lethargy or.
So you need to tell me what are the symptoms of mild, moderate, and severe hyponatremia. What is the symptom of acute hyponatremia, chronic hyponatremia?
In the mild to moderate, there is a decreased activity, confusion. In the acute setting, it could be associated with the seizure.
So the most severe manifestation is what is the severe hyponatremia? Acute severe hyponatremia is seizures or impending respiratory failure. These are the acute things. These conditions you have to immediately treat. This is important because your treatment will depend upon. Moderate symptoms will be headache and uncontrolled projectile vomiting. That will be there. Mild symptoms will be irritability, lethargy, vomiting, nausea, not feeling well, and frequent falls. Particularly in older people, the main history is that they will fall down very often, and osteoporotic fractures can happen in that regard. So, what do you think? This is acute or a chronic hyponatremia? Let's put it this way.
Sir, this is a chronic condition, but with some infection or some stressful event, it is.
How do you define acute hyponatremia?
Sir, by the altered sensorium seizure or
duration of illness?
Duration of less than 48 hours.
So less than 48 hours. So do you think this could be acute? So what you're trying to say is correct, is that he had some problem which became worse during this period. So there seems to be an acute component also. So less than 48 hours is important. Why is 48 hours important?
Sir, because it takes time to maintain the osmolarity. To maintain
if the sodium goes down, the brain cells will swell. The brains will then develop osmoles inside, and they will try to get water basically out of their system, and this takes up to 48 hours. That is why this 48 hours is absolutely important. So in this setting, you have a child with recurrent admissions for dehydration, vomiting, and hyponatremia, and now presenting with worsening. There's a 2 to 3 year history of weight loss. What specific one thing on examination will give you the diagnosis? Now this is very easy now.
Sir, pigmentation.
So that is very important. Carry on.
So in this case, there was hyponatremia. Sodium was 116 millimole per liter, and there is associated with the hyperkalemia. Potassium is 6.2. Child having normal birth history and family history is normal and developmentally normal child. So there is no history of trauma and radiation. There is no any history of admission till the 6 year of age. Child having multiple admission after the 6 to 7 year of age. There is no history of chronic cough, fever, or history of contact TB. No history of increased height gain or development of the secondary sexual characteristics.
Why are you asking for that?
Sir, if we think about the adrenal, then it could be the most common cause of the adrenal. It is a congenital adrenal hyperplasia.
Would a congenital adrenal hyperplasia survive till 10 years of age?
Sir, no.
So impossible. So if they are surviving, that will be a simple case of virilizing. So nobody will survive. They would have died in the first 1 to 2 months of age. So while it is important to consider, it is also important to not unnecessarily put that. The people will ask, that means that you don't understand that they would have died by this time. So this cannot be CA. I think this is very, very clear. This is a acquired cause. So your questions are very relevant from an acquired perspective. So when we talk about, so let's put it this way. You now have already given me information that there is hyponatremia, hyperkalemia, and dehydration. So now your diagnosis is?
Sir, it is pointing towards the adrenal because last defect.
Now, congenital form is out. If you had congenital, nobody will survive till 8 or 10 years of age. There has to be acquired. So if you logically talk about the acquired cause, what is the most common acquired cause of RAS defect?
At 8 years old.
Acquired cause, most common cause will be autoimmunity.
So most common will be Addison's. So adenocortical insufficiency, Addison's disease. Because pseudohypoaldosteronism, why were it present at this point of time? That is anyway unusual. Now, in that, the most common situation will be autoimmunity or tuberculosis. So you asked about chronic cough, fever, or contact with tuberculosis. But autoimmunity, what else you should have asked?
Sir, any history of means seizure, vitiligo, or any nail
abnormality, mucosal changes, mucocutaneous candidiasis, family history. You should specifically say no features of hypocalcemia or autoimmune disease in the child because it is often very, very common. So we talked about acquired or later presentation of an adenocortical insufficiency. That is what it is. So you talked about tuberculosis. We have talked about APS1 as a possibility. Anything else?
Sir, we can talk fever with rashes, like acute abdominal pain. It can be the possibilities, like adrenal hemorrhage or meningococcal.
You have to go for the case. I'm not talking about generic. I'm asking about this case. This case started at 8 years according to you. So it can't be that hemorrhage happened and then he's in between. And there's something which is evolving. Anything else very important in a boy?
Adrenal leukodystrophy.
You have to specifically ask about question of spasticity, neurological functions, brothers being affected, maternal uncle. So just by saying family history is not enough. You have to go deep that there is no history of similar illness in brothers or maternal uncles. There is no history of neurological disorders because it may be a spectrum. So now if we talk about that, a child who has got recurrent episodes of dehydration with hyponatremia, hyperkalemia, very, very clearly, it is an adrenocortical insufficiency. It is an acquired form and inacquired. In terms of diagnosis, we have discussed autoimmune Addison's will be number one. Second would probably be tuberculosis, which is there and because of the setting. And third will, of course, be an important possibility would be in the setting of an ALD in that perspective. Could this be a AAA syndrome? A problem in the in which you have got atelectaima. Why don't you ask for history of atelectaima and echolalia in this case? You didn't ask the history for that.
Sir, I will include this all in my differential diagnosis.
So you will include AAA syndrome in the differential?
No, sir. In this, I will not include because there is no any microcephaly. There is no any microcephaly. There is no any feeding difficulty.
Why will you not include AAA syndrome in this diagnosis?
Because there is pigment hyperkalemia. Hyperkalemia is there.
Potassium is high. So you have to specifically answer me that. It is a trick question. I'm basically asking that if you have hyperkalemia, you don't have to think of AAA syndrome. That becomes less likely in that perspective. Familial glucocorticoid deficiency.
Familiar glucose, there will be also hyperkalemia.
Hyperkalemia will not be there. So pigmentation will be there in both of them. And we'll talk about that. But hyperkalemia is very, very clear. There is a combined glucocorticoid, mineralocorticoid defect which is there. Carry on.
So no any history of seizure, hair loss, or the vitiligo. So in the general examination, patient having no obvious dysmorphism or no any disproportional short stature, though no any paler icterus cyanosis. Patient having pulse rate of 146, tachycardia, and BP was lower side, and patient having pigmentation on the hand and the buccal mucosa. Patient is looking dehydrated and having catechic look, and patient having normal genitalia. SPL is 5.5 centimeter, testicular volume is 3 ml, and pubic hair is 1. So this is the picture of our patient having catechic look, and there is an increased pigmentation over the hand and the knuckle area. So by the anthropometry wise, height, patient having height of 125.8 centimeter, that is minus 1.67 standard deviation, and weight is 17.5, that is weight is more affected, minus 2.94, and BMI is 11.1. So in the summary, a 10-year-old male who developed recurrent vomiting since the age of the 8 year, with history of multiple admission for the same reason, with increased pigmentation since 2 years, with the recurrent hyponatremia, normal genitalia, with the history of gradual weight loss.
Now, if you had not given me potassium, then probably we could have been a bit confused whether it is an ACTH resistance versus a primary adrenocortical abnormality. But even then, what is against ACTH resistance, even if you forget about potassium in this thing?
Against the ACTH resistance.
Like AAA, like isolated cortisol deficiency. Let's put it this way. Because of AAA syndrome or ACTH receptor problem, familial blue cortisol.
Severity of illness, one thing, and tall stature can be the possibility.
Very importantly, dehydration will not be that.
Severity.
That is not the severity. Because that will behave like SIAD. This is cortisol deficiency. They will either be euvolemic or theoretically they will be hypervolemic. So if you're talking about recurrent dehydration, it means it has to be an adrenocortical defect in that perspective. So carry forward.
So in this case, possible diagnosis, it is pointing towards the adrenal insufficiency in this case, as child having the hyponatremia with the hyperkalemia, but the child having dehydration, so chronic kidney disease is ruled out in this condition, and other cause of the hyponatremia with the polyuria and dehydration is also ruled out, like diabetes or hypercalcemia like condition.
So DK, of course.
It is not. So we are dealing basically with the adrenal insufficiency. So it can be due to the three causes: central cause, or either the impaired ACTH effect, or due to the combined adrenocortical defects. So central cause could be the not possibility because of the high potassium. There is a pigmentation, and there is no any history of radiation or CNS infection. Impaired adrenal effect could be not possibility in this case because of the high potassium, late onset, and there is no any syndromic features. We can think about our possibilities toward the adrenocortical defect because there is a hyperkalemia with the hyponatremia, and there is an increased pigmentation since the 2 years.
So out of these three, which one have the lowest sodium and which one have the highest sodium?
Sir, adrenocortical defect having the lowest sodium because the combined effect, and the highest sodium will be due to the central effect.
And ACTH resistance will have the highest potassium. So they are the aldosterone defect. You don't know what aldosterone defect. Yeah, they will have the highest potassium in that perspective.
So we are dealing with the combined adrenocortical defect. So it can be due to the three reasons in this, most commonly CH, but there is no history of admission since 6 years, no any precocious puberty, so it is ruling out. Acquired form could be the possibility, but there is no any history of drug history, no history of contact TB, no any history of infection, or no acute abdominal pain. Adrenoleukodystrophy, we can think in this case because of the age of presentation is favoring, and there is no other autoimmune association like vitiligo, skin lesion, or any hypocalcemia is there in this condition.
ALD, the other thing also which we see more often is that often glucocorticoid deficiency predominates as compared to mineralocorticoid. So this is a classical case of adolescence, I would say, mostly autoimmune cause. And whatever has been said and written,
mostly autoimmune cause.
Autoimmune. Tuberculosis is very, very unusual. We haven't seen that many causes of tuberculosis now with adrenal problems. So I would keep a acquired autoimmune cause of not the APS1, but other forms of also adrenal insufficiency is very common. In that case.
So by investigation wise, cortisol was low at the time of the hyponatremia. ACTH was more than 2000, and the glucose, there is a hypoglycemia. Sodium was low, high potassium, and there is a normal calcium, phosphorus, and ALP for the autoimmune workup. In this case, possible diagnosis, we are dealing this patient with the recurrent hyponatremia due to the adrenal insufficiency, query due to the adrenoleukodystrophy, or due to the some autoimmune condition. So by investigation plan to send a very long chain fatty acid level in this patient.
That is more for exclusion because that will have a diagnostic category. If you want to confirm autoimmune cause, which antibody will you suggest?
Sir, interferon GA.
That is for APS1. For adrenal, which is the specific one?
21 hydroxylase.
21 hydroxylase antibody will be what is done in that patient. So I think that will be the most likely situation.
For the management perspective, we have to stabilize this patient. We need to give bolus of the 350 ml at the 10 to 20 ml per kg, correct the hypoglycemia, and we need to give hydrocortisol bolus dose 50 milligram per meter square, followed by the continuous dose, continuous hydrocortisol at the 100 milligram per meter square. And we need to avoid multiple hydrocortisone, multiple bolus because of the urinary loss. And potassium level generally improved with the hydrocortisone. If it is a refractory case, then we can use the calcium gluconate and insulin dextrose. After 48 hours, we can switch over to oral form. And as the hydrocortisone dose decrease from the 50 milligram per meter square, then in case we can get the fluorocortisone.
Yes.
So for the
So acute management of adrenal insufficiency, very importantly, you have to give saline, which is most important. And you also have to give hydrocortisone, because hydrocortisone will have mineralocorticoid effect in that perspective. Very important point which you said, that we prefer infusion versus recurrent boluses because the cortisol binding globulin has got a saturable kinetics. As soon as the level goes above 700, it will be lost in the urine. So better to give continuous infusion than recurrent boluses, which is important from that perspective. So I think this was a very, very interesting and a very clear-cut case which was there in that perspective, which showed how we need to distinguish between different causes. If you have both hyponatremia and hyperkalemia, you're talking about adrenocortical largely. So primary ones will basically have pigmentation and hyperkalemia. Hyponatremia will happen in all three. Remember, hyponatremia will happen in all three. But if you have a primary cause, you have pigmentation and hyperkalemia. So these are the two things. You know the diagnosis now very clearly. Now, of course, hemorrhage and all infiltration will be very acute. So this is more like a chronic acquired cause, looks like an autoimmune situation. ACTH resistance, AAA syndrome, MC2 receptor problem or a MRAP problem will present mainly with hypoglycemia, failure to thrive, mild hyponatremia, normal potassium and severe pigmentation. They will be the most pigmented. Adolescents are not that pigmented. They will be much more pigmented than that perspective. And of course, ACTH deficiency, and this also we'll talk about, will have no pigmentation and will have a normal potassium. So if you look at two things, pigmentation and potassium, you will know how the diagnosis is and how do we go forward from that perspective. The treatment depends upon how much is the duration and how much are the symptoms. So duration we talk about more than 48 hours as chronic, less than 48 hours as acute. So the duration is less than 48 hours and you have got severe symptoms like seizures or impending respiratory failure, sodium other than 120, you have to immediately give a 3 to 5 ml per kg of 3% saline. You can rise the sodium by 9 to 12. If there are mild to moderate symptoms like only headache and confusion, like maybe in this case you can say, you will have 120 to 130. You will give slow dose of 3% saline and build up by 8 to 9. Now remember, if you give somebody with cortisol, especially in somebody who has adrenocortical insufficiency, the sodium levels may rise rapidly. So you have to be very cautious that the sodium levels do not rise very rapidly more than that, because that can cause a problem. If they are rising a lot, you have to either do a relowering using a AVP, and that becomes important from that perspective. If the duration is about 48 hours or you don't know, often you don't know how long is the symptom, then you assume it is chronic. Then depending upon symptoms, if they are severe, you still may have to give 3%, but the dose is there, the same dose, but then correction is slower. After that, your aim is to correct seizures and then hold. Don't build up very rapidly. And if it's mild to moderate with nausea only, no need of 3% saline, you give restriction, treat the cause and you will go. So symptoms and duration will decide what treatment to do and how do we go forward from that perspective that becomes relevant from that regards. So I think that was a very, very interesting aspect which we discussed today. You can explore our books, courses and applications. Fluorocortisone, a good drug for cerebral salt wasting? Yes. So main treatment now, this is a very debatable issue whether the cerebral salt wasting is actually a condition or not. A lot of people debate that, but main treatment is a lot of sodium chloride and fluorocort will help in that regards. What are the reason for cortisol deficiency in this case? The MRI, I think, is normal on that. we are looking at some genetic causes as a possibility to work it up on that. We are waiting on that in that situation. There are other questions. Cutoff for mild, moderate, and severe. There is no sodium cutoff. Now, this is important to remember, Dr. Amit, that we depend upon the symptoms. We don't go by the levels, because the symptoms and the presentation depends upon the rapidity of fall. So if somebody is at 120 who is having seizures, who is coning, that is severe to me. But if somebody is 115 and doesn't have that symptoms, chronic liver disease, it's not severe. So it's a combination. So if you remember that algorithm, duration and symptoms, they will give you the diagnosis and how to go forward on that. For sodium correction in hyperglycemia, 1.8 is what we usually recommend, and some 2 is also okay, but 1.8 seems more reasonable, Dr. Munir, in that.